It's a routine list for a cataract surgery. Your first patient of the day is Mrs. Fussy Fussison, who's extremely keen on having spectacle-free vision for all distances post-operatively. You plan for the latest generation of a multifocal IOL, and the surgery is going according to plan so far. The nucleus has been emulsified and you're almost done removing the last few chunks of the cortex. Oh, but wait! Your probe has just caught the posterior capsule. Suddenly staring at you is a small but significant problem. You have an array of options to place the IOL after managing this complication, but knowing Mrs. Fussison, you know that placing the lens in the bag is your best chance to prevent getting a earful from her tomorrow. As cataract surgeons, we come across many a complication during surgery, the most common being posterior capsular rent. Even amongst the best of us, the rate is about 0.4 to 3.6%. The stage of irrigation and aspiration is one of the most common stages at which this complication may occur. A posterior capsular rent alters the surgical plan and may make in-the-bag implantation of an IOL impossible. Although techniques exist to place the lens in the posterior chamber without support of the posterior capsule, these techniques can lead to refractive surprises as titrating the effective lens position becomes challenging. With improved IOL technologies, it is becoming increasingly important to place the IOL in the bag to ensure the best possible visual outcomes. The technique of posterior continuous curvilinear capsulorhexis, described by Howard Gimbel for preventing visual axis opacification in pediatric eyes, can also be used in an eye with a compromised posterior capsule. It is noteworthy to mention here that not all PC tears are associated with vitreous loss. This is due to the Berger space, which is a potential space in the patellar fossa between the posterior capsule and the anterior hyaloid phase. Conventionally, for managing PC tears, the surgeon injects a dispersive OVD into the anterior chamber from the side port before withdrawing the probe from the eye to avoid a sudden collapse of the chamber. A forceps is then introduced through the main port and the PC tear is converted to a strong rhexis. In an ideal scenario, this technique ensures that the IOL can still be placed in the capsular bag. However, despite best efforts, some amount of fluctuation of the anterior chamber is inevitable during withdrawal of the probe and introduction of the forceps. These sudden fluctuations in the anterior chamber depth can obliterate the Berger space, leading to disruption of the anterior hyaloid phase with resultant vitreous loss and possible extension of the PC tear. What if there was a way to prevent this? A one-instrument technique to tackle the situation. Behold, the vacuum rhexis, a new technique for posterior capsulorhexis which may potentially minimize this complication and improve the chances of in-the-bag IOL placement. We advocate this technique for a small central or a paracentral PCR during the IA stage without vitreous loss. Surgeons will also have to be experienced with the use of a coaxial IA system. In this video, a small central PCR has occurred during IA. Notice the absence of vitreous evidenced by the freely floating posterior capsular flap without any distortion of its margins. There also is no evidence of obstruction or flow into the cannula by vitreous strands. The surgeon has a separate parameter preset for the scenario, which he changes with the help of the foot pedal. The aspiration port of the cannula, which is oriented either upwards or sideways, is made to engage one edge of the tone capsular margin, and the foot pedal is depressed to the beginning of position 2 to grasp the margin firmly. The IA probe is then moved in a curvilinear manner either clockwise or anti-clockwise, depending on the surgeon's comfort. As it can be seen here, the posterior capsule is fairly elastic as compared to its anterior counterpart, and thus the direction of forces should always be inward. Notice how the surgeon regrasps the margin at regular intervals to aid in better control of the rhexis. This animation shows how the direction of movement of the IA probe must be constantly changed in order to ensure that the vectors are always centripetal. Once the rhexis is completed, it is extremely important to inject a cohesive OED into the anterior chamber and the bag, as sudden withdrawal can still disrupt the anterior hyaloid phase, leading to vitreous loss. As the OVD fills the anterior chamber, the surgeon simultaneously switches off the irrigation of the IA probe and gently withdraws it from the anterior chamber. A foldable IOL can then be gently placed into the bag after filling it with OVD. After centration of the IOL is ensured, the OVD is carefully washed out from the anterior chamber. The rest of the procedure is the same as for a routine cataract surgery. We've also found it possible to use this technique for paracentral rents with good success. We feel that this alternative technique may increase the chances of in-the-bag placement of the IOL, as the continuous irrigation and reduced repeated instrumentation maintains the anterior chamber better without leading to much fluctuation in chamber dynamics. In our series of 12 eyes, we found this technique to be feasible and reproducible, with none of the patients having any vitreous loss or extension of the tear after the vacuum rhexis. We were able to successfully implant a foldable IOL in the bag for all the cases, which remained stable at the third postoperative period with no tilt or decentration. Although this technique has a steep learning curve, the vacuum rhexis can ensure safe landings after a rip.